Anyone? What is the next one? This is choanal atresia. This is pre-auricular sinus, and this is an omphalocele. So these all have been reported. You really need to be careful if somebody is having Graves' disease, and this is what the standard guidelines recommend for management of hyperthyroidism during pregnancy. So now we move on to a slightly different aspect. This is a 34-year-old lady having diabetes for 3 years. We increasingly keep on seeing these patients that pre-existing diabetes type 1. Now we are having more of type 2 and is on sitagliptin, metformin and glimepiride. Slight suboptimal control. So what is the target HbA1c if you are planning to have? If somebody should be conceiving, 6.5 is the target. So the lady has to come down. So what do we do in this case? Continue same treatment, shift to premixed insulin plus metformin, shift to basal bolus regimen plus metformin, or shift to basal bolus or premixed insulin annual and stop metformin. Again, any opinion? So there is actually no evidence to guide you that what should be done in this case. So if you look into the evidence, if somebody has done an RCT, so might be very small. So none of the guidelines say what ideally should be done in this case. But my practical opinion is that you make minimal changes once the lady conceives. So somebody is conceiving, you get to know at 4 to 5 weeks. 6 to 12 weeks is the most crucial time for organ formation. So you don't want glycemic fluctuation at that particular time. So I give the option of basal bolus regimen in most of my patients. Only if they refuse, I will offer an option of premixed. Metformin might be optional. Again, a gray area, lots of controversies. Somebody might be comfortable with continuing metformin, others might not be. So metformin is plus minus, but preferable if you are shifting the patient to basal bolus regimen, reaching an HbA1c of 6.5, it might be the most aggressive form of therapy, but you don't have to go for any transition, because most of the ladies with type 2 diabetes, once they conceive, the fasting target is less than 95. The post-meal target is 2 hours is less than 120. With premixed insulin, it's very difficult to reach all those points. So in my practice, almost everybody who is planning to conceive or is already pregnant is on basal bolus regimen, not on a premixed insulin. Metformin is plus minus. And this is also, again, this is just general recommendation for ADA. A1C should be less than 6.5. Counseling is very, very important. Some medications actually might be very, very relevant in this case. So many of them will be on an AC inhibitor or an ARB. Many of them will be also on statin. So these are all contraindicated during pregnancy. So if somebody is on AC or ARB or statins, that has to be stopped. And the person should be shifted to safer medications. So these are the BP medications like methyl dopa, nifedipine, labetalol and clonidine, safer in pregnancy. Atenolol again should not be used if somebody is planning a pregnancy. So these are the guidelines which are there. A1C is less than 6.5%. Folic acid, actually the recommended dose is around 400 micrograms. So most of the preparations will have 5 mg. I came across an interesting article. I have not shown the slides, but excess of folic acid, so it diverts the 1-carbon metabolism towards hyperhomocystinemia. So folic acid 5 mg, 10 mg throughout pregnancy. Recommendation is only 400 microgram. So if you are giving excess, there is a tendency of hyperhomocystinemia, and that actually increases the tendency for GDM. So folic acid should be used judiciously only for the recommended period. Again, more a domain for the gynecologist. Obviously, you need to screen for complications if there is pre-existing diabetes, including renal complication, because both renal and retinal complications, they tend to worsen during pregnancy. So such screening is mandatory. If there is requirement, can be CAD evaluation can also be a part if it's required. Thyroid function testing is definitely recommended in type 1 diabetes, optional in type 2 before conceiving, and also weight reduction is very, very important. So there are some complicated situations like pituitary lesions or adrenal lesions. I will not go into that. But a very common condition is hyperprolactinemia. Prolactinoma might not be common, and most of them will be iatrogenic. So many of this, so somebody getting a domperidone tablet is like bread and butter. So every morning somebody will pop up a tablet which will have a proton pump inhibitor and a domperidone. So again, that can actually cause increase in prolactin. Levosulfide also is notorious for doing it. So these two molecules, if somebody is getting, the prolactin level might go up and even might interfere with fertility. So all these ladies, they come with MRI and all, but actually what they require is the right medicine and proper counseling. But even mild elevation in prolactin can interfere with fertility. So we need to maintain prolactin in the normal range. So we have been discussing obesity, and this is something which is important. This window for conceive prior to conception is very, very important, because obesity is getting increasingly common and it has multiple implications, including reduced fertility and need for ART. Even if somebody is going for ART, the risk of success actually goes down. So something very, very important. And there are meta-analysis that with increasing weight, with increasing BMI, the chance of becoming pregnant and live birth, they both actually goes down. And if you actually intervene by even lifestyle intervention, so the risk settles down, so that there is a higher chance of becoming pregnant and conceiving. And we are all thinking about all talking about the importance of obesity. So there is obviously the chance of development of GDM if somebody is obese. There is a chance of development of preeclampsia or hypertension. But again, so there is actually carryover effect into the fetus also. So obesity, the metabolic, there are early epigenetic changes, metabolic programming of the fetus that can actually translate to higher metabolic risk in the fetus and future risk of cardiovascular disease and diabetes. So this is a window which has very, very long-term implication. So weight loss and in Indian context, even maintaining the right balance of carbohydrate, protein, and fat, and also the micronutrients, they all become important. So finally, to summarize, so it's a very broad area, and the endocrinologist might have multiple roles, but obviously treatment of pre-existing disease is important. If it's not there, if somebody is obese, so that also requires understanding, and that can have both implications for pregnancy, for the fetus, and also for long-term metabolic and cardiovascular outcome of the progeny. And very, very important, we need to be careful about choice of medications. Many of the problems are iatrogenic, and you need to avoid medications which have teratogenicity or can interfere with fertility potential. And if somebody is having any of these complications, they are usually very serious just prior to conceiving and during pregnancy. So we have a very, very low follow-up rate for GDM. So we should all be doing an OGTT at 6 weeks in women with GDM, but it's hardly done. So it's very important to have long-term follow-up in all these women. Thank you for your patience.